Good morning, everybody. My name is Max Konig. First of all, it's an absolute pleasure to be here and to speak in front of you. Thank you for the organizers for setting this meeting exactly at the end of my paternity leave, so that was very kind. I'm a rheumatologist and physician scientist at Johns Hopkins. My passion is in advancing cellular and immune effector cell therapies for autoimmune diseases. We don't have a fancy company name yet, but I would like to convince you that we have a lot of exciting assets, and I want to talk to you about one of them today. So first, I'm going to introduce to you something we call bispecific T-cell engagers that are autoantigen driven. These are BAITEs, and this is a new bispecific immune effector cell therapy that we have developed and dramatically improved over the last 3 to 4 years. This new therapy was really developed in a collaborative effort between rheumatologists, immunologists, and immuno-oncologists, including Dr. Anthony Rosen, who is the Vice Dean of Research at Johns Hopkins, Dr. Bert Vogelstein, who is a pioneer in cancer genetics, and also in immunotherapy over the last few years, and myself. And my lab really focuses on precision immunotherapies for autoimmune diseases. I probably don't need to convince you that autoimmune diseases are a big problem. They're a major cause of morbidity and mortality in the United States. They affect over 50 million Americans, and the market space is approximately 150 billion. What unites all of these is that all drugs that we have at our disposal today confirm an increased risk of infection. And when I see patients in the hospital with rheumatic diseases or autoimmune diseases that are admitted, they come for 2 reasons. The therapies that we're giving them are not potent enough, so there's lack of efficacy, or the therapies have too many off-target effects, so patients are admitted for infectious complications. Precision therapies that could overcome this by selectively eliminating the drivers of the disease without touching the normal protective immune responses have remained elusive. And that's where our therapies come in. As a very quick primer of immunology and autoimmunity, there are autoreactive B cells and T cells. And depending on the disease is primarily driven by either autoreactive T cells or autoreactive B cells. These therapies will require different therapy. These diseases will require differently targeted therapies. At the center of many of our autoimmune diseases are autoreactive B cells, and these B cells secrete immunoglobulin, that's called the autoantibody, and at the same time they express antibody on the cell surface, that's the B cell receptor. They're identical in sequence, and they recognize the same thing as self-protein or self-nucleic acid in the body. In many of our diseases, we know that these antibodies are actually what drives damage in the target tissue. The kidney of a lupus patient, the muscle of a myositis patient, or the joint of a patient with RA. Over the last 3 years, we have seen a dramatic shift in how we approach autoimmune diseases. From monoclonal antibodies that deplete all B cells that have not been effective in many autoimmune diseases, we have gone to cellular therapies that target B cell lineages and that have shown transformative results. The promise of long-term disease remission due to deep depletion of a B-cell compartment. However, there are a lot of autoimmune diseases, so not every patient has severe and refractory disease. So there are major barriers to bring cellular therapies to patients with autoimmune diseases. The first one is the cost of manufacturing administration, right? We're talking about $500,000 to $1 million. There's a lack of infrastructure in the United States that's really hard to build, that makes it incredibly hard to scale these therapies. We're thinking about giving these therapies to millions of people, many with mild or moderate disease that currently would not be considered for cellular therapies, and I would argue should not be considered for cellular therapies. And then the risk of toxicity. One, with cellular therapies, you're doing something where you provide space for the cells to engraft, that's called conditioning. That alone is usually cyclophosphamide and fludarabine. It suppresses the immune system. It sets patients up for infection. The second is cytokine-related toxicities, and that's a direct correlate with the degree of T-cell activation. So what if we could change the paradigm and instead of trying to wipe out whole B-cell compartments, selectively wipe out the drivers of the disease that only make up about 1% of the total B cell pool. That would leave 95 to 99% of protected immune responses completely untouched, and this would result in patients having the same potent responses that we're looking for with CAR T cells without the risk of infection. So our approach, one of our approaches, is a new technology called Bispecific Autoantigen-T cell engagers, or BAITEs. Similar to bispecific antibodies that you know, we're going after B cells. But instead of wiping out the whole B cell compartment, think of blinatumomab that wipes out all CD19 positive B cells, which leads to risk of infection and significant CRS and ICANS, we're trying to get rid of only the autoreactive cells. And if we can do that, then now we have the ability to control disease without increasing the risk of infection and potentially even achieve cures. And more importantly, if we make these therapies precise enough and potent enough, we can now escalate the therapy to whatever level we need to achieve complete disease control. And we would be able to apply these therapies to patients with mild disease or even patients at risk of disease. So the approach that is underlying the BAITE technology works very similar than a bispecific T-cell engaging antibody that you're familiar with. One end engages an immune effector cell, for example, CD3 epsilon, on a T-cell, engaging and activating the T-cell in the presence of antigen. The other end, though, is not an scFv that targets CD19 or BCMA, but is the autoantigen itself. And because we use the autoantigen, we're able to selectively bind B-cell receptors of autoreactive B cells that are drivers of the disease, but not any other B cell. And the proposition is that if we do this right, we're able to activate any bystander T cells without engineering to selectively cross-link, activate, and then kill the autoreactive B cell. We're working on several indications. The first indication that we went after is called antiphospholipid syndrome. It's a primary cause of thrombosis, stroke, heart attack, and pregnancy loss in the United States. And therapies haven't really evolved in 30 years. We're anticoagulating these patients. There is no real competitive market. This disease is not uncommon, it's just underappreciated. 1 in 2,000 people in the United States have APS. That's about half the patient population of lupus. More importantly, if you go into the hospital and you just count the patients that come through the door with stroke, heart attack, or pregnancy complications, 10% of these patients have these pathogenic antibodies. It is under-recognized. Importantly, we know what the pathogenic antibodies target, and we know that if we block these pathogenic antibodies in animal models, we can prevent the disease. So that's what we're trying to do. There are two important parts of the technology that took us a lot of time to perfect. One, beta-2 GPI BAITEs linking the autoantigen that's targeted in APS with an scFv needed to be precision engineered so that we could get rid of off-target toxicities. So the beta-2 glycoprotein 1 on the left, you see that in its native conformation, at high concentration showed off-target binding, and through our engineering, we're able to completely abrogate it. So now it only binds to autoreactive B cells. The second point is that we put a lot of effort in perfecting the scFv and the construct. And by doing that, we are able to achieve not only incredibly high potency, these BAITEs kill in the nanomolar or high picomolar range, affinity range, but also exquisite specificity. So you can see that as we uptitrate the amount of BAITE in co-culture with polyclonal T cells, we're able to completely get rid of the autoreactive B cells, but our normal B cells are completely unharmed. Similarly, on the right, when we look at interferon release, in the presence of autoreactive B cells, we see an expected interferon release profile. In the absence, in the presence of normal B cells, there's none. So this allows us to really escalate the therapy now over many, many orders of magnitude safely without risking any kind of cytokine release syndrome in healthy people. Yeah, we're done. Okay, I apologize. Okay, we can abrogate antibody protection, We think of this as a platform technology. We're working on APS, rheumatoid arthritis, other indications. The list is long. And we have several patents that we've filed on this to protect the IP. Finally, I invite you to transform the way we think about autoimmune diseases. This has been an incredible ride over the last 3 years, from rituximab to CD19 CAR T cells to just in the last few months, bispecific antibodies. And I think this is going to be the future of autoimmune disease treatment. So thank you.
Thanks. Steve.